Respiratory Module Part 2, Audio 2. In this group of the slides, we will proceed or we will continue with pneumonia, but here we will discuss community-acquired atypical pneumonia caused by special types of the microorganism as Mycoplasma pneumonia and influenza virus, and the most important serious pandemic pneumonia that is caused nowadays by coronavirus. It's a community-acquired atypical pneumonia. It's an acute febrile respiratory disease characterized by patchy inflammatory changes in the lung, confined to the alveolar septa and pulmonary interstitium. It's different from the typical pneumonia that confined to the alveoli. The term atypical denote cough patient presented with a cough, moderate amount of sputum, sometimes it is dry cough, with the absence of the finding of the consolidation and lack of alveolar exudate that is normally found in the community-acquired typical type of the pneumonia when the alveoli are filled with exudate, inflammatory exudate. Here there is lack of the alveolar exudate with moderate elevation of the white cell count. These types of the pneumonia caused by a variety of microorganisms. What are the types of the microorganism that cause this type of pneumonia? Mycoplasma pneumonia, which is the most common, particularly found or seen among children and young adults, usually occurs sporadically or as local epidemics in a closed community, as in the schools, military camps or prisons. يعني بالسجون بالمدارس أو بالكامبس للجيش، يعني مكان يعني تجمعات الجيش أو الكامبات of the soldiers or the military camps. Other causes that might cause this atypical type of the pneumonia is influenza type A and B, respiratory syncytial virus, adenovirus, varicella, measles. All type of virus may cause this type of pneumonia, which is atypical pneumonia. Also, chlamydia pneumonia and Coxiella burnetii cause of Q fever. The pathogenesis of atypical pneumonia. When the organism become attached to the respiratory epithelium, because there is a specific receptor in the respiratory epithelium that attached by the microorganism, whether it's a virus or mycoplasma or any type. When there's this attachment took place, followed by necrosis of the cell, and of course, according to this attachment, there would be inflammatory reaction. In the alveoli, there will be interstitial inflammation. If we remember about the pneumonia with typical type of the pneumonia, there in the typical type of pneumonia, the most striking inflammation is intra-alveolar exudate. Actually, it started with a congestion, and there would be inflammation, which is acute inflammatory cell infiltrate inside the alveoli. Here, there would be interstitial inflammation with outpouring of fluid into the alveolar space. The alveolar space filled with fluid. So, on chest X-ray, it might simulate to the typical type of bacterial pneumonia, but it is not. It is not like typical type of bacterial pneumonia. Regardless the cause, whether it's a virus, whether it's mycoplasma, the morphological pattern in atypical pneumonia is similar. The process patchy and may involve the whole lobe, may involve the bilateral involvement of the both lungs or unilateral involvement of the one lung, and sometimes involvement of the entire lung. And here would be the problem of the respiratory difficulty and breathing difficulty. Grossly, the inflamed area are red, blue, congested, the pleura is smooth and inflamed, which is opposite to what we have seen in typical bacterial pneumonia. Microscopically, what we would see, the inflammatory reaction is largely confined to the wall of the alveoli. That means the inflammation is in the alveolar wall. The septa widened, edematous, and usually contain mononuclear inflammatory cells, which include lymphocyte, macrophage, histiocyte, and plasma cells, which is opposite to what we have seen in bacterial typical pneumonia, in which acute inflammatory cell in neutrophil exudate filling the alveoli. Here, the inflammatory reaction is largely confined to the wall of the alveoli. Septa widened, edematous, the inflammatory cells, mainly lymphocyte, histiocyte, sometimes plasma cell. The alveolar spaces are free of exudate. So, however, in full-blown diffuse alveolar damage, when the inflammation or the infection is so severe, sometimes it would be alveolar damage with hyaline membrane might develop. That's a superimposed infection. You know what is hyaline membrane? That means that it's the starting of adult respiratory distress syndrome. This is a major problem that would happen in this type of pneumonia, atypical pneumonia. In uncomplicated cases, it's subside of the disease. It's followed by resolution. Look at here at the microscopical picture and the view of atypical type of the pneumonia. This is alveolar space, devoid of any inflammation. The inflammation confined to the wall, to the alveolar septa. Here, the alveolar septa is widened and infiltrated with the inflammatory cells. Most of the inflammatory cells are lymphocyte and histiocyte, and some plasma cell. If we concentrate and focus on we can see occasional plasma cell. Here, there is no hyaline membrane. Actually, this might be the starting of hyaline membrane. Maybe this is deposition of the fibrin or something like inflammatory reaction that line the alveoli, but it's not. Here it's not. We are still in the first stages or in the acute stages of the disease. We come here to other two pictures, microscopical view of chronic atypical pneumonia, in which this is the hyaline membrane. Actually, this is the problem that we have faced nowadays, especially with the coronavirus infection, that we would discuss it in detail in next slides. This is also, we have seen that there is inflammation in the alveolar septa and widened of the alveolar septa, edematous and congestion. Another microscopical view of atypical pneumonia. You can compare it with this picture that we have seen in the first group of slides. Actually, it's different, completely different, because it would be in the first slides or in the former slides, the alveolar space are filled with the acute inflammatory cells, neutrophils. Here there is no, and it is just confined to the alveolar septa and widened alveolar septa, edematous and congestion, and with the inflammatory cells, which is mainly mononuclear cells. Clinically, the patient presented with the symptoms, respiratory symptoms, but the clinical symptoms is extremely variable, depend on many factors. Some of the diseases in atypical type of this respiratory tract infection, sometimes mild and transient, and the patient just few days and recover without any complication. So the clinical presentation of the patient extremely variable. It is, of course, like chest cold. Patient is chesty, cold. Patient might have mild fever. It might be cough, mild cough with dry cough, sometimes harsh cough, sometimes patient come high fever, rigor. So the clinical presentation of the patient is really variable. Sometimes present patient with fulminant life-threatening infection, especially those immune-compromised individual, in cardiac patients, in COPD patient, chronic obstructive airway, in asthmatic patient, renal patient, those patient with underlying disease. The disease here might be fulminant life-threatening. The onset of acute illness with fever, headache, malaise, fatigue all over the body, cough, sometimes dry cough with minimal sputum. Sometimes if the alveolar capillary block, that means if there's severe inflammation with hyaline membrane, and edema, I think the respiratory distress would be more striking. Regarding mycoplasma antigen and polymerase chain reaction, PCR test for mycoplasma DNA is available. Other most important, actually serious disease that might have the same feature of atypical pneumonia is SARS, severe acute respiratory syndrome, previously caused by SARS, unrecognized coronavirus SARS-CoV, that appeared in 2002 in China, then appeared in other Asian countries as Hong Kong, Taiwan, Singapore, Vietnam, Toronto. It's appeared as an outbreak, as upper respiratory tract infection that able to extend to the lower respiratory tract infection and induce viremia. Viremia means there's viral replication of the virus in the blood. Patient becomes severely ill within 2 to 10 days of the after exposure to this type of the virus. Might be direct contact from person to person, or through secretion or fecal-oral transmission. The same feature clinical presentation: fever, myalgia, pain in the muscle, diarrhea, chill, rigor, followed by the cough and dyspnea. The lungs show diffuse alveolar damage and giant cells. Here we are in the most serious, worrisome topic that make all over the world changed dramatically nowadays is coronavirus COVID-19. Here in these slides, we have a discussion about this type of the virus. Actually, from the studies, that new study, because this is a new type of virus. Actually, this is new biologically mutated type of coronavirus that caused this pandemic. You know, it's not just epidemic to the confined to the geographic to the confined to the country, or confined to the zone, geographical zone, or to the continent. It is involving, infecting all the people all over the world, actually all the globe, which make us so stressful, make us so changing our life, make me giving you lecture through this stadium. Coronavirus disease, COVID-19, is a new strain that is discovered in 2019 and has not been previously identified in a human. There are many stories actually which say that this virus coming from the bats because it's discovered in China. Some of the stories, it's not proved actually, because it's not proved that this disease coming because the Chinese people having a different type of the food from the animals, from the bat, from the snakes. So they thought that it is coming from the animal, zoonotic. So the coronavirus are zoonotic, meaning they are transmitted between animal and people. Detailed investigation found that SARS-CoV was transmitted from the civet cat to human, and MERS-CoV from camel to the human. Because there are, we know this is not a new virus. Actually, it's not a new virus, because we had the same virus, SARS, and they have the same family, MERS-CoV virus, from the camel. But this pandemic, we haven't seen such a pandemic since decades. Several non-coronaviruses are circulating in animals that have not yet infected any humans. The common signs of the infection include respiratory system symptoms. Unfortunately, it is the same as any flu virus, that patient presented with fever, cough, but here sometimes passing as a respiratory, as mild flu, as simple as such. influenza بسيطة جدا. Respiratory symptom, fever, cough, myalgia, 3 days, and patient cured. But sometimes it becomes so severe, and the patient presented with shortness of breath and breathing difficulty. In more severe cases, the infection can cause severe pneumonia and severe acute respiratory distress syndrome, and unfortunately may lead to death. Actually, because the things that here in coronavirus, because it's involving the entire lung, it's not like typical bacterial pneumonia, which involves one lobe, confined to the lobe, or here sometimes becomes so severe that lead to severe pneumonia that involving the entire lung. These two pictures showing the features of the virus. The characteristic feature of the, actually it is ugly looking and crazy, like look at the spikes here of the virus. These are made of protein. These are spikes that attach to the receptor in the body and the respiratory tract, not only in the respiratory tract, but also in other organs, such as in the blood vessels, and in what else, in the liver. So this which activate the enzyme. Actually, they have been say that they attach to the angiotensin converting enzyme receptor 2. This China coronavirus, the symptoms of 2019 and how it spread by patient, has fever, chest pain, chills, rigor, patient irtijiff, rapid heartbeat, of course, as any infection that has rapid heartbeat, breathing difficulties, pneumonia, kidney failure. At the same time, patient has headache, sore throat, cough, and shortness of breath. Of course, comparing to the symptoms, it's the same symptoms of any flu that we encounter during winter. But please don't panic. Don't panic because not everyone has the symptoms of the flu that the flu caused by the influenza virus has coronavirus. So we shouldn't be panic. However, it would be scary indeed. Anyway, this is the chest radiograph, chest x-ray in the hospital. The patient, day 3. Look at it. Patient, there's progressive diffuse opacity, especially here in the base of the lung. It is consistent with adult acute respiratory distress syndrome, which is the serious and severe complication of this coronavirus infection. What is the standard recommendation to prevent infection spread? All of us know that regular hand washing, the hygiene, the covering the mouth and nose when coughing, sneezing, this is ABC of prevent infection even in flu, simple flu or common cold virus. So we are here dealing with more crazy virus, more serious virus. So we have to be committed to the recommendation to prevent infection. So regular hand washing, covering mouth and nose when coughing and sneezing, thoroughly cooking meat and eggs. Look at here, thoroughly cooking meat and eggs, because it was thought that this virus coming from eating raw bats and snakes, which the bad habits of Chinese that make all the globe, all the world crazy. I think they should have found other food item to eat rather than bat and snake. I don't want why they are sticking to such bad habits anyway. So even the meat and egg should be cooked very well in order, if there's any chance to have virus in it, we have to cook them thoroughly in order to avoid getting infection with the subvirus. Avoid close contact and anyone showing symptom of respiratory illness such as coughing and sneezing, even the patient that has flu or common cold, simple one, we have to avoid close contact to them in order to avoid the chance to be infected. It might be coronavirus patient. What happens to people lungs when they get COVID-19? The almost all serious consequences of COVID-19 feature pneumonia, lung infection. People who catch COVID-19 can be placed into 4 broad categories. The least serious, so we have 4 categories. Patient with infection with COVID-19, coronavirus, we have 4 categories. The first one, which is the least serious one, are those people who are subclinical, the people who have the virus but have no symptoms, as any other virus. All of us might encounter a virus. The first category of the group that we said, they are subclinical, a group in which there is no symptoms but they have an infection. Those people that come next are those who got an infection of the upper respiratory tract, which means a person has fever and cough and maybe mild symptom like headache and conjunctivitis. So the symptoms as any simple flu or common cold virus infection. Those people with minor symptoms are still and are able to transmit the disease and the virus, but may not be aware of it, because they think that they have just flu, but can transmit the disease into other people in close contact with them. The large category Those that would be positive for COVID-19 and the people most likely to present in the hospitals and surgery that develop the same flu-like symptoms, but a bit more severe than the previous group. And of course, they keep themselves off work. That to say they are away or they stay home because they feel more tired than the previous group. The fourth group will develop severe illness with features of pneumonia and difficulty in breathing. In Wuhan, in China, it worked out that those that have tested positive and thought that to have medical help or medical advice, roughly 6% has severe illness. According to the WHO, say that the elderly people or those people with underlying problem such as high blood pressure, renal problem, heart problem, lung problem, as COPD, chronic bronchitis, emphysematous patient, bronchiectasis, what else, asthmatic patient, or diabetes or renal disease are more likely to develop serious illness as acute respiratory distress syndrome when infected with the COVID-19 or severe pneumonia. So this picture showing how coronavirus can kill. The symptoms: the coronavirus attacks cells in the respiratory tract, showing runny nose, cough, sore throat, and fever. Spread: the novel coronavirus first spread to human from an animal. They thought they are coming from the bats, from the snakes, from the food that raw food that they had eaten. The virus transmitted between human and droplet, from person to person by the droplet, actually from coughing or sneezing, touching or shaking hands, because there are many stories and many stories that they say that this virus stay and remain in the place when there's in the droplet remain in the surfaces for hours or sometimes for days. Therefore, we have to be more careful to be in close contact with the if we touch things, especially nowadays when the epidemic is in its high rate. It enters humans through the nose and through the mouth, then finds a host cell in the respiratory system, such as one in the nose. The host cell then bursts, and other nearby cells in the body are infected with the virus. As soon as it gets inside the body, the host cell become burst, and then nearby cell or the closed cell would be more infected, and the virus replicate itself inside the body. The death of the virus, most victims actually die from the complication, including pneumonia or from swelling in the lung, because it's involved entire lung actually. Also cardiac injury, sometimes renal failure. So many organs in the body might be involved and affected seriously in infected people. Severe pneumonia can kill people by causing them drown in the fluid flooding the lung, because it's acute respiratory distress syndrome that the fluids fill all the alveoli and it's appear as the lung drown in the fluid flooding their lungs. That's flood فيضان يعني لأن الرئة of the patient رئة المريض تصبح completely entire lung to be affected and infected, and their fluid السوائل fill all the alveoli with the infection, of course, of the interstitial tissue and alveolar septa and edematous. فتصبح يعني الرئة كأنه غارقة في السوائل. فطبعا هذا it would prevent the exchange of the gases in between the alveoli and the blood. Virus also causes swelling in the respiratory system, which can make it hard for the lung to pass oxygen, as we said, into the bloodstream, leading to the organ failure, hypoxia, and death. How does the pneumonia develop? When people with COVID-19 develop cough and fever, they say that it is a result of infection reaching the respiratory tree. There are passages that conduct air between the lung and the outside. Then the lining of the respiratory become injured, which lead to the inflammation. The inflammation in turn irritate the nerve ending that in the lining of the airway. So just a speck of the dust can stimulate a cough, and the cough become so irritating that the patient have continuously coughed and unable to withstand any irritant that might reach the air passages. If this gets worse, it goes past just the lining of the airway and goes to the gas exchange, because the inflammation involved the alveoli and the alveolar wall. When there would be inflammatory fluid outpouring into the alveoli, so the air sac at the bottom of the lung become filled with the fluid, end up with pneumonia. Lung flooded with the fluid become filled with the inflammatory material, which make the lung or the alveoli unable to exchange the gas in between alveolar sac and the blood. This will lead to reduce the ability of the body to take in enough oxygen and get rid of the carbon dioxide. That is the usual cause of death with severe pneumonia. How can the pneumonia be treated? Actually, so far there is no established treatment for COVID-19, and we don't have anything that can stop people getting COVID-19 pneumonia. However, we are trying to make all the measures in order to stop the spread of the virus in between people. But sometimes when the patient got infection, so we couldn't stop pneumonia, especially in those people who are immune compromised, immune suppressed, on chemotherapy, cancer patient, cardiac patient, lung disease, they have lung disease, as we said, COPD and others. People trying all sort of medication, actually, hopeful that they can get benefit from any antiviral treatment in order to treat pneumonia caused by the COVID-19. There are certain various combinations of viral and antiviral medication that could be effective. At the moment, there isn't any established treatment apart from supportive treatment. Patient with COVID-19 infection, severe pneumonia, should be admitted to the hospital in order to put it in ICU, or respiratory care unit, or intensive care unit, to be under ventilator in order to get enough oxygen and to give him the artificial ventilator breathe instead of the lung, till the lung resolve from the infection and inflammation and get ready to work again. So we ventilate them and maintain a high oxygen level until the lung to be able to function in normal way and the patient recover. Patients with viral pneumonia are also at risk of developing secondary infection. Of course, that would be treated with antiviral medication and antibiotic if there is secondary bacterial infection. Actually, now they try to give the patient, and I think there is the trial would succeed, especially in China, because I think they prove, according to the many stories and many posts that we received, they prove to use antimalarial hydroxychloroquine and chloroquine antimalarial drug medication. They think that this is working in patients with COVID-19 infection. I hope so. I hope this drug would be good for those patients and would be beneficial for the people, that especially those people with severe infection and got pneumonia or adult respiratory distress syndrome. COVID-19 pneumonia is different from the most cases that people are admitted to the hospital for. Most type of pneumonia that we know and that we admit people to hospital are bacterial, as we know, community-acquired pneumonia, typical type of the pneumonia. The most common type of the bacteria, as we discussed in the first group of slides, is caused by the pneumococcal pneumonia, the same streptococcus pneumonia, or other type of the bacteria, Haemophilus influenza, Pseudomonas, any other type of the bacteria. The evidence that the pneumonia that caused by COVID-19 may be particularly severe. There are many cases of coronavirus pneumonia tend to affect all of the lung instead of part. I told you before, lobar pneumonia or bacterial pneumonia usually involved part of the lung, lobe, two lobes, one part may be unilateral, rarely bilateral. Here, in this type of pneumonia caused by the COVID-19, mostly it is affect all of the lung, entire lung. كل الرئة تتأذى. So once we have an infection in the lung, and if it involves the air sac, then the body response is first to try and destroy the virus and limit the replication. Generally, people age 65 and over are really at high risk of getting pneumonia, not only by COVID-19, but any respiratory tract infection, flu-like illness, they are more at risk of getting pneumonia. But here, with COVID-19 or coronavirus infection, they are at high risk of getting the pneumonia actually, as well as the people with medical conditions such as diabetes, cancer patient, COPD, heart disease, kidney, liver, those smoker, and infant age 12 months and under. So they consider, in some researchers, they consider the age is the major predictor of risk or death from pneumonia. As you know, that is, the pneumonia is always serious for older age group. However, we have good treatment for pneumonia nowadays, especially for bacterial pneumonia, but here for the viral pneumonia caused by the COVID-19 is still on trials. It's important to remember that no matter how healthy and active the patient is, but the age is important that should be considered in such a patient. Therefore, those patients, elderly patients, should get away from any contact or any people that suspected to have COVID-19 infection, because normally the immune system of those patients are weakened with the age. So it's making hard for our body to fight off infection and disease. I hope we could cover the COVID-19 infection, which is the major problem nowadays that make all the community in really stressful situation, from the governmental, the people, from the first high-ranking people to them, to any patient or any person in the community. We have to help together. As we covered the COVID-19 infection, pneumonia, and respiratory tract infection that consider the major, as we say, the major problem nowadays that change the globe dramatically, actually change the style of life change everything in our life. We try to cover this in few previous slides. Hopefully that we could find good treatment for this type of infection in order to get rid of this crazy virus. As well, we could back to our normal life, normal lectures, normal habits. However, we have to be more careful when we communicate with each other in the future. Other type of pneumonia that is acquired in the hospital, nosocomial pneumonia, which is pulmonary infection that acquired in the course of hospital stay. When the patient stay for a long period of time in the hospital, it's acquired this type of pneumonia. It's most commonly among hospitalized patients with severe underlying disease, maybe CVA or immune suppression or prolonged antibiotic treatment, or patient with stroke, or those with a mechanical ventilation. They represent the higher risk group. Gram-negative routes like Enterobacteria and Pseudomonas staph aureus are the most common pathogen that cause this type of the bacteria, pneumonia. Aspiration pneumonia is other type of the pneumonia also, which is caused by aspiration of the gastric content, either while the patient is unconscious or during repeated vomiting. The resultant pneumonia is partly chemical because of the swallowing of this gastric acid, which is highly irritant to the lung, and because of the effect of the gastric acid, and partly bacterial. It is necrotizing type of pneumonia that may be fatal, especially in those debilitating patients with a high incidence of the abscess formation, and foreign body giant cell granuloma are common. This is a gross view of the lung in aspiration pneumonia, showing numerous abscesses. Actually, this is dark gray in color, the abscess formation, because one of the complications of the aspiration pneumonia. This, can you see in the lung, the microscopic view of the lung in aspiration pneumonia, showing gastric contain with inflammatory cell macrophage seen in this is giant cell. Look at here, aspirated material with giant cell and macrophage within the microscopic view of the aspiration pneumonia, showing macrophages and inflammatory cells surrounding aspirated gastric content. This is the gastric content, and this is the inflammatory cell and macrophages in the alveoli. Lung abscess. What is the lung abscess? You know, we took this. We know about this term in the general pathology. Localized area of suppurative necrosis. But here we can see this suppurative area, localized suppurative necrosis within the pulmonary parenchyma. The cause of introduction of the causative microorganism may arise in the following mechanism. It might be due to the aspiration of the infective material from carious tooth, or infected sinus, or tonsil, especially after oral surgery, anesthesia, alcoholic patient, those with depressed in the cough reflex، يعني ما يقدرون يكحون، ذول البيشنت اللي عندهم CVA، ذول البيشنت اللي عندهم ما عندهم cough reflex cannot cough، اللي عندهم carious tooth، aspirated ممكن infected sinus، or might be due to complication of necrotizing type of bacterial pneumonia, or mycotic lung infection. Mycotic lung infection, that means caused by the fungi, maybe lead to the lung abscess. Bronchiectasis also might be one of the causes of the lung abscess. Following bronchial obstruction, as in tumors and obstruction might lead to the lung abscess. Septic embolism, if you remember, septic thrombophlebitis or infective endocarditis might be one of the causes of that lead to the lung abscess. Impairment of the drainage and in the bacteremia. The morphology. Abscesses vary from few millimeters to large cavity, 5 to 6 cm in diameter or larger. The number and localization of the abscess depend on the mode of their development, the cause of the development of this necrotizing lesion. The abscesses that result from the aspiration of infected material are more common in the right side and is single, and it is tend to occur in the posterior segment of the upper lobe. The anatomical situation of the abscess is important to be known, or in the apical segment of the lower lobe. So the most common site is in the right side, single, tend to occur in the posterior segment of the upper lobe or in the apical segment of the lower lobe, because these locations represent the probable course of aspirated material when the patient recumbent يعني نايم. فممكن يصير الاسبريشن of this infective material وين تصير أكثر شيء بالجهة اليمنى بالposterior segment of the upper lobe or in the upper apical segment of the lower lobe. Abscesses that develop in the course of the pneumonia or bronchiectasis are commonly multiple according to the site of the bronchiectasis. وين أكل pneumonia يصير بها الأبسس multiple. إذا كانت localized يصير localized، إذا كانت multiple مثلا ممكن مثلا بالبرونكونيمونيا يصير multiple، وكذلك بالبرونchiectasis according to the site of these infections. Septic emboli and abscess arise from the hematogenous receding, as in bacteremia. Also multiple may affect any region of the lung. أي مكان ممكن يتسبب به. The focus of the suppuration in large abscess inevitably rupture into airway. Inevitably rupture ممكن يعني ينفتح على airway that may be partially drained. ممكن يكون يطلع as a sputum أو يعني ممكن patient cough it out as a necrotic within the material within the sputum. طبعا by radiological examination we see air fluid. It's appear by chest x-ray air fluid كأنه لأن هو cavity وبيها a necrotic material and there is air fluid. So when there is air fluid by chest x-ray, this is a diagnostic of the abscess. But of course according to the cause there are many causes of the abscess. يعني هو مو it is usually there is underlying cause of the abscess. يعني مو يجي الابسس ويصير لحاله باللung. There should be underlying cause: pneumonia, bronchiectasis, aspiration, infective material, bacteremia, septic emboli, whatever the cause. Occasionally the abscess may rupture into the pleural cavity, which lead to the fistula, bronchopleural fistula, which lead as a consequence of this empyema, broncho or pneumothorax might occurs or develop. This is a gross appearance of the abscess showing irregular shape cavity within the lung parenchyma filled with the necrotic hemorrhagic tissue. This is one of the, and this is also an abscess formation. This is multiple abscess formation. Cavities within the lung parenchyma filled with necrotic tissue. Other complications are the embolization of septic material to the brain, which give rise to the meningitis and brain abscess. Sometimes other complication of the abscess, emboli of this abscess, lung abscess to the brain, that might lead to the meningitis and the brain abscess. Histologically, there is suppurative inflammation surrounded by the fibrous scar and suppurative inflammation, necrotic tissue, necrotic infective inflammatory exudate surrounded by the fibrous scarring with mononuclear cell and infiltration, including lymphocyte, plasma cell, and macrophage. The manifestation of the lung abscess are much like those of bronchiectasis. Patient has fever, patient with cough with copious amount of foul smell, bad smell, sputum, sometimes hemoptysis. Patient have malaise, as any type of the severe infection actually. Patient with clubbing finger, weight loss, anemia. About 10 to 15 of bronchogenic carcinoma, the infective abscesses occur. Also, secondary amyloidosis may develop in chronic cases. Now we are coming to the new topic, which is chronic pneumonia and pneumonia in immune-compromised host. Chronic pneumonia include tuberculosis. We are coming to the very old subject or topic actually. Very old one and very important one. Decline the incidence of this disease nowadays because of the vaccination. So tuberculosis is a communicable chronic granulomatous disease caused by which type of the bacteria? Mycobacterium tuberculosis, usually involving the lung, but might involve any organ in the body. Epidemiology: 1.7 billion individuals are infected worldwide, with about 8 to 10 million new cases and million deaths per year. Tuberculosis here in our countries and in the developed country decline, as I told you, because of the vaccination, especially in the first week of the when the baby born, new baby born, in the first week of his life, he got the first vaccine that he received or got in his life is a BCG or for tuberculosis against the tubercle bacilli. Therefore, the decline so much, the rate is very low. However, in some countries, especially in Asia, in poor countries, in poor communities, are still there is still a high rate of this disease among those people. TBs among medically, economically deprived person flourish whenever there is poverty, crowding, chronic debilitating illnesses, as I told you. Old people, people with diabetes, chronic renal disease, chronic debilitating disease, malnutrition, alcoholism, heart disease, immune-compromised patient, HIV, all of these patients are more prone to get tuberculosis or tubercle bacilli infection. Infection with Mycobacterium tuberculosis typically lead to the development of delayed hypersensitivity, which can be detected by tuberculin or Mantoux test. After 2 to 4 weeks after infection has begun, intracutaneous injection of 0.1 ml of PPD, purified protein derivative, induce visible, palpable induration, about 5 mm in diameter, that peak in 48 to 72 hours. What signified positive tuberculin test? It signified cell-mediated hypersensitivity reaction to tuberculous antigen. Etiology: Mycobacterium tuberculosis are slender, rod, that are acid-fast. It's very important criteria, that have high content of complex lipid. This also to be highlighted. Readily bind with the Ziehl-Neelsen. So Ziehl-Neelsen stain is the stain that is used to stain acid-fast bacilli, and it's appear red in color. Mycobacterium tuberculosis hominis. Actually, this type of the Mycobacterium is responsible for the most cases of tuberculosis. The reservoir of the infection usually found in the human with active pulmonary disease. يعني موجودة بالpatient اللي عندهم active disease. Transmission is usually direct by inhalation. So by inhalation of airborne organism in aerosol generated by expectoration. Then, oropharyngeal and intestinal type of tuberculosis contracted or get by what? By contaminated milk, but with mycobacterial bovis. This is another type of the mycobacterium, which is still seen in some countries that have contaminated or unpasteurized milk. Mycobacterium avium intercellular, this type of which are less virulent type than the other type of mycobacterium, but can be seen in or can infect the people or immune-compromised people with AIDS and in about 10 to 30%. The pathogenesis. In a previously unexposed immune-competent patient, look at here and concentrate here, focus onto the pathogenesis of tuberculosis. In a previously unexposed immune-competent patient is centered on the development of targeted cell-mediated immunity that confer resistance to the organism, which result in hypersensitivity to the TB antigen. Because the immunity of this patient, it is unexposed patient, high immunity, good immunity, so there's tissue hypersensitivity against tuberculosis antigen, that such as caseating granuloma. شو تسوي caseating granuloma and cavitation. This patient, unexposed, unvaccinated patient, exposed to the or infected by tuberculosis bacilli, the reaction against this tuberculosis by the tissue hypersensitivity in the form of caseating granuloma and cavitation. Once virulent strain of mycobacteria gain entry into the macrophage, the organism is capable of inhibit normal microbicidal response by manipulation of endosomal pH and arrest endosomal maturation. So the microorganism would manipulate endosomal pH and arrest توقف endosomal maturation. This will lead to the impairment of phagolysosome formation. There is no phagolysosome that would kill or engulf the microorganism or the TB bacilli in order to kill it. So the TB bacilli will remain inside the macrophage, which lead to the microbial proliferation. The earliest phase of primary TB in non-sensitized individual is characterized by bacillar proliferation. There is no sensitization. There is no patient is unsensitized, non-sensitized, unexposed, no hypersensitivity reaction. So there is bacillary proliferation inside the macrophage and also outside the macrophage, which result in bacteremia and seeding in multiple sites. There would be bacteremia. However, the patient with primary tuberculosis are asymptomatic or with mild symptoms because the cell-mediated immunity usually develop 3 weeks after exposure. Process mycobacterial antigen. We're coming to the pathogenesis. The antigen presented by the macrophage in major histocompatibility class 2 context to the CD4 T helper lymphocyte. The macrophage secrete interleukin 12. CD4 plus become activated and would secrete gamma interferon. Activated macrophages in turn release a variety of mediator, which is important, like tumor necrotic factor, responsible for the recruiting and activation of the monocyte, which differentiate into the epithelioid histiocyte, which are the characteristic of granulomatous reaction of the tuberculosis. Nitric oxide, also powerful oxidizing bactericidal agent and generation of reactive oxygen species that have antibacterial activity. This is a schematic demonstration of the pathogenesis of the primary tuberculosis, as we discussed it in last slides. This is a TB bacilli, this is a macrophage. The macrophages, the TB bacilli attached to the macrophages, there is inhibition or maturation of the endosomal manipulation, lack of acid pH, ineffective phagolysosome, proliferation, unchecked bacillary proliferation, which lead to the bacteremia or seeding in multiple sites. Primary tuberculosis macrophages present this antigen to the T cell, which lead to the increased sensitivity of this T cell, which are responsible for the tuberculin positivity, hypersensitivity, and also secrete gamma interferon. Gamma interferon make the macrophage activated, in turn produce tumor necrotic factor to differentiate monocyte and recruiting and differentiate monocyte to become epithelioid histiocyte, which are the main component of the granulomatous reaction in tuberculosis. Primary tuberculosis is a form of disease that developed in a previously unexposed unsensitized patient. So, elderly patient, immune-compromised patient may lose the sensitivity to the TB bacilli, so may develop multiple primary tuberculosis. However, patient, because it is unsensitized, unexposed, so the symptoms become mild. The source of the organism in the primary tuberculosis is exogenous, because patient is not exposed before. 5% of newly infected people have significant disease. The inhaled bacilli morphologically are drained into the distal airspace of the lower part of the upper lobe and upper part of the lower lobe. So in primary tuberculosis, the main part of the lung that involved is the lower part of the upper lobe and the upper part of the lower lobe. Sensitization developed about 1 to 1.5 centimeter. The area of very wide inflammatory consolidation merge the gone focus. In most cases, the center of this focus undergo caseous necrosis, which is the characteristic feature of tuberculosis. TB bacilli might be C-free or within the macrophage that drain to the regional lymph node, which also showing caseating. Gone complex is the combination of parenchymal lesion, the lesion or the caseous necrosis, tuberculous lesion that found in the lung with nodal involvement, lymph node involvement, what is called gone complex. During the first few weeks, there's also hematogenous lymphatic dissemination to the other part of the body. 95% of the cases, there would be cell-mediated immunity that developed to control about 95%. In 95% of the cases, this development of cell-mediated immunity try to control the infection. So, the gone focus that the primary lesion, parenchymal lesion with lymph node involvement undergo fibrosis. And fibrosis followed by the calcification, which can be detected by chest X-ray. يعني إذا ناخذ أشعة للمريض نشوف فد فوكس أو كون ليجن بالضبط تشبه يعني هيك فد calcification كأنه calcified focus. This calcified focus, we have to raise suspicion that patient might have a primary tuberculosis, but fibrous and calcified. Histologically, what can we see and what we expect to see? There is granulomatous inflammatory reaction with caseating necrosis. That might be multiple caseating granuloma with calyces to be seen macroscopically. The granuloma surrounded by the fibroblastic. This is a gross appearance of the lung showing gone complex of a primary. It is the lesion, small, subpleural, pleural lesion, because the lesion sometimes close to the pleura, and associated with the caseating necrosis or the involvement of the lymph node. So parenchymal lesion with lymph node involvement called gone focus. Secondary tuberculosis or reactivation tuberculosis. This disease arises in a previously sensitized host, opposite to the primary tuberculosis, in which happened or arise in patient which unsensitized, unexposed patient. Here, secondary or reactivation in previously sensitized host. It might follow shortly after primary TB, or sometimes commonly many decades after the initial infection, might be due to the lower in the immunity of the patient or reactivation of dormant primary tuberculosis. Might result from exogenous infection. Secondary tuberculosis localize typically and classically in the apex of one or both lobe. In the apex is different from the site of the primary tuberculosis, in which in the lower part of the upper lobe or in the upper part of the lower lobe and close to the pleura. Here in secondary, due to the high oxygen tension, here in the apex of the one or both lobe. Patient previously sensitized, so patient pre-exists hypersensitivity to the hypersensitive reaction to the bacilli. It excites or incite or provoke prompt and marked tissue response that tend to wall off the focus patient, because previously sensitized patient, so there is hypersensitive reaction. So this is prompt and marked tissue response to wall off the focus. In this type of the secondary tuberculosis, in this type of the infection, regional lymph nodes are less prominently involved than that seen in the primary tuberculosis. Cavitation readily in the secondary form, resulting in dissemination along the airway, and this is the important source of infectivity because the patient now raise the sputum that contain large number of the bacilli. The initial lesion usually small focus of consolidation 1 to 2 centimeter in the apical part of the lung, the apex. Sharply circumscribed gray, white, yellow area that with a variable amount, of course, of the caseous necrosis and peripheral fibrosis. The active lesion show the same. It's tuberculosis, coalescent tuberculous granuloma, Langhans giant cell, central caseation, and tuberculous TB bacilli can be demonstrated in early lesion, but it's almost impossible to find them in the late stage. This is actually the lesion with the cavity in the apical part of the lung. This is a morphological lesion or microscopic showing of the granuloma showing Langhans giant cell. Look at the nuclei which are arranged at the periphery of the lesion. This is a granulomatous reaction of the tuberculosis. This is caseous necrosis. Caseous necrosis surrounded by the epithelioid cell and surrounded by lymphocyte and fibroblastic reaction. Here another microscopic view of caseating granuloma. Look at the caseous necrosis in the middle and surrounded by the epithelioid histiocyte, and this is a lymphocyte and surrounded by the fibroblastic reaction. The apical lesion may heal spontaneously because of the good immunity of the patient, or by therapy, by treatment of the anti-tuberculous treatment or anti-tuberculous drug, and because the tuberculous bacilli need to be treated for a long period of time before many years they started the treatment, and they last the treatment about 9 months and then decrease it into 6 months, and as I think they are just 2 months last the treatment of the anti-tuberculous medication or anti-tuberculosis drugs, or sometimes might extend along different pathways. Progressive pulmonary tuberculosis. The apical lesion might enlarge with expansion or enlargement of the area of caseous necrosis, might be erode into the bronchus, evacuate the caseous material. So the caseous material, when evacuated, leaving a regular cavity which bounded by caseation material that are walled by fibrous tissue. With adequate anti-tuberculous treatment, this process may be stopped, although the fibrosis or the healing by the fibrosis might distort the pulmonary architecture. Now we have irregular cavities, free of caseating necrosis, may remain as cavity or maybe collapse in the surrounding fibrosis. Sometimes the treatment of the anti-tuberculous drug is inadequate, or the host defense mechanism, the immunity of the patient, is low or impaired. The infection might spread and via dissemination through the airways or through vascular system or through lymphatic channels. This is a figure showing cavitation, appearance of the lung in a progressive pulmonary secondary TB. This is also cavity. This is an apical cavity. Actually, this is secondary TB, but it's progressive. More than one lesion and cavitary lesion might be erode into the bronchus or bronchioles, leaving the cavity. Might progress into miliary tuberculosis, which is one of the most serious complications of tuberculosis. When the microorganism get through into the lymphatic, then into the lymphatic duct, and then finally eventually empty into the venous, return to the right side of the heart and then to the pulmonary artery. The individual lesions are either microscopic or small, visible, about 2 to 3 millimeters in diameter, foci of yellow-white consolidation scattered throughout all the lung, entire lung involved, because the TB bacilli disseminate through the lymphatics into the venous system, to the right side of the heart, through pulmonary artery, then get back to the lung, but involving the whole lung with a small, visible, tiny foci of consolidation. The miliary lesion might be expand, maybe coalesce to yield almost total consolidation of large lesion, or might involve the whole lobe. This is a miliary tuberculosis. Look at the white, small, scattered, widespread lesion of consolidation, granulomatous reaction of tuberculosis. Look at here. Here. There are very small, different sizes of the miliary tubercle lesion involving almost the entire lung. TB pleurisy. Sometimes progression of pulmonary tuberculosis may involve the pleura. Of course, when involving the pleura, it causes irritation, inflammation in the pleura, causing pleural effusion within the pleural cavity. TB empyema with pus formation or sometimes obliterative fibrous pleurisy might develop. Sometimes endobronchial, endotracheal, laryngeal TB, all these might be involved as a part of progressive tuberculosis, especially when there is infective material spreading either through lymphatics or from the expectorated infective material or cavitation, the cavity erosion of the tuberculous cavity, cavitary lesion inside the endobronchial, inside the tracheal, whatever lead to the spreading of the infection to those organs. Systemic miliary TB. When infective foci in the lung seed the pulmonary venous return to the heart, patient have infective foci in the lung that seed to the pulmonary venous return, pulmonary veins. Pulmonary veins return to the heart, left side of the heart. So, any organ of the body, because there is spreading of the Microbacterium tuberculosis bacilli through the blood from the left side of the heart into the whole of the body. Any organ of the body might be affected because of the seeding of TB bacilli in any organ might be possible. So lesion resemble that seen in the lung, maybe seen in the heart, maybe in the liver, adrenal, spleen, meninges, brain, fallopian tube, epididymis. This is a pleural effusion in patient with pleural tuberculosis. Pleural effusion, fluid in the pleural cavity obliterate the lung. We cannot see the lung because here the fluid filling the pleural cavity. Clinically, the patient with localized secondary tuberculosis may be asymptomatic. However, the systemic manifestation may be insidious in onset, related to the cytokine released by the macrophages, tumor necrotic factor, and interleukin-1. So the patient may have fever, may have weight loss, malaise, loss of appetite, night sweat, high ESR, lymphocytosis, sometimes lymphopenia in the CBC. What else we have in those patients? The characteristic feature in those patients, we have fever, night sweat. So the night sweat and anorexia and loss of appetite and sometimes loss of weight because of the cytokine that are produced or secreted by the macrophage, which is the tumor necrotic factor and interleukin-1. Sometimes the patient have cough, sometimes cough with or without sputum, pleuritic chest pain because of the pleurisy or involvement of the pleura. Sometimes if there is pleural effusion, patient with a difficulty in the breathing, because sometimes patient expectorate sputum, streak of the blood, many symptoms which is variable according to the degree of the infection and according to the immunity of the patient and how the patient combat the disease. The diagnosis, of course, and this is very important, and by chest, we have, when we receive the such a patient, any chest patient, any patient with chest infection or suspected chest lesion, we have to do chest x-ray for the patient. And also we have to get the sputum with 3 consecutive days, sputum, early morning sputum, and it should be real sputum. It's not just saliva. And we can know by cytological examination, we can know this is because we have to find alveolar macrophages inside the sputum, otherwise it is saliva. So staining by gram stain, and also by acid-fast bacilli. Acid-fast bacilli is very important to identify with Ziehl-Neelsen stain to identify the acid-fast bacilli. So acid-fast bacilli is very important to be identified by Ziehl-Neelsen stain, which is appear as red in color, or by fluorescent rhodamine method. On 2 consecutive sputum specimens or 3 consecutive days, which is very good to confirm the diagnosis. And also we have to culture the sputum, would take about 10 weeks. It's take actually a long period of time. By PCR method for TB bacilli, DNA recently used, and it is very quick and accurate method of diagnosis. Here is the Ziehl-Neelsen stain for TB bacilli. Look at the TB bacilli, which appear as a red, slender rods inside the macrophages or outside the macrophages in this specimen. Also, this is a Ziehl-Neelsen stain which demonstrates or identify the bacilli, red, slender rod shape, red in color by Ziehl-Neelsen.